Hello and welcome to this FIT webinar. My name is Dr. Helena Rolfe, Clinical Director for the West Yorkshire and Harrogate Cancer Alliance. This webinar is to explain the new West Yorkshire and Harrogate FIT pathway, following on from recent NICE and BSG evidence-based recommendations. I'd like to introduce my colleagues who are here today to kindly help make this education piece. Rick.
Hi, Helena. My name is Rick Saunders. I'm one of the colorectal surgeons in Leeds, and I'm also the Clinical Director of the Optimal Pathways Group for West Yorkshire and Harrogate Cancer Alliance, looking at colorectal cancer.
Welcome, thank you. And Rob.
Hi, I'm Rob Eastham. I'm Clinical Lead for Planned Care with a focus on digital at the West Yorkshire branch of the Integrated Care Board, and I'm also a GP in Leeds.
That's great, thank you both. So Rick, could you start by telling us what you feel the fundamental changes are in this new pathway?
Thank you. Yes, so we've used FIT as a colorectal community for a number of years now for low-risk patients and in the bowel cancer screening programme. And the fundamental change with this pathway is that we're now talking about using FIT for 2-week wait patients. And the reason that's been recommended is that there's very good evidence now that that picks up colorectal cancer in patients more effectively than previous pathways. And that evidence has been endorsed by the Association of Coloproctology, the British Society of Gastroenterology, NHS England, and is now NICE accredited. And so it's robust. So the fundamental change that we're proposing from the Alliance perspective is that we move away from the historical age criteria and symptom-based criteria for referral as a 2-week wait referral, and that we move to a system where all patients over 18 who have GI symptoms and there is concern about the possibility of bowel cancer, is that they're assessed clinically in primary care, they have routine blood tests to exclude iron deficiency anemia, and they then have a FIT test. There will then be some interpretation required in primary care as to the next step, and my colleague Rob here will go through that in much more detail.
Great, thank you. And Rick, what is your view of the pathway?
I think it's a really positive step forward for colorectal cancer care. I think it's much more objective than symptom-based referral pathways, and I think it also allows us potentially to pick up colorectal cancer quicker in younger patients who would currently not be picked up with the current 2-week wait referral guidelines.
Great, so that's a massive improvement.
Yeah.
Thank you. So Rob, could you please talk us through the pathway from a GP's perspective?
Sure. So the pathway begins with a patient presenting to GP in primary care with undiagnosed abdominal symptoms which could be suggestive of colorectal cancer. So by that I mean, for example, unexplained weight loss and abdominal pain. It could be unexplained rectal bleeding. It could be a persistent change in bowel habit, or it may be that the patient is self-reporting or be found on examination to have an abdominal mass. So really important at this point to do a physical examination, which includes a rectal examination. And then from here, there are basically 2 possible next steps. So you have one group of patients that, and this is quite a small group of patients, especially compared to the previous pathway, that it would be appropriate to refer immediately on the 2-week wait referral form onto the pathway. I'll come back to the criteria for those patients in a moment. The second, and by far the biggest cohort of patients, it would be more appropriate to request a FIT test and also to request blood tests, including full blood count, UNEs, ferritin, and any other additional blood tests that might be considered appropriate at the time, depending on the outcome of the history taking and examination. So just going back now to the first cohort, this is the group that we would refer immediately on the 2-week wait pathway. So what are the criteria for those people? So if we look at the Cancer Alliance flowchart, you'll see that there are 3 boxes near the top of the flowchart for those patients. The first group on the right are patients with an abdominal mass. So they should be referred immediately on the 2-week wait pathway and also request a FIT test at the same time. And you might say, well, why would you request a FIT test if you're referring an abdominal mass immediately as a 2-week wait? Well, the reason is to assist our colleagues in secondary care to appropriately triage the patients, because it may be that depending on the result of the FIT test, the patient might be more appropriate directed towards, for example, a CT scan rather than a colonoscopy or vice versa. If we now move on to the next group of patients that would fit immediate referral on a 2-week wait pathway, you'll see on the left-hand side of the flowchart that patients with an anal or rectal mass or anal ulceration, they should also be referred immediately on a 2-week wait, and there's no FIT test required for these patients. And then the third group of patients that should immediately be referred, and I'm really pleased that we've been able to agree this for clinicians and for patients in the West Yorkshire region, because I think it's a really important safety net, is those patients who have persistent concerning symptoms but are unable to complete a FIT test for a variety of reasons. Now, this is a small but significant minority of patients but they can immediately be referred on a 2-week wait form if it's considered appropriate to do so. So they're the patients we immediately refer. A small group compared to previous, much bigger group of patients, they would have a FIT test and blood tests. Perhaps important now to just briefly allude to the role of the pathway navigators. So we're lucky that the Alliance is funding the pathway navigators, whose role it is to support patients through the process of completing a FIT test. Now, what that means does depend a bit on locality, so check in your locality on the appropriate referral information what the role of the navigators is. We're looking in Leeds, for example, that the pathway navigators will proactively chase patients who have not submitted a FIT test following a request by the GP, and only after 3 unsuccessful attempts to contact the patient will the patient then be referred back to primary care. What do we do then if the FIT test is positive, and by that I mean 10 or higher, if the result is 10 or higher? Well, these patients need to be on the 2-week wait pathway. So again, we're looking in Leeds that if the result is found to be 10 or higher, then Leeds Teaching Hospitals will contact the patient and escalate it automatically onto the 2-week wait pathway. So there's no need for GPs in Leeds to complete a referral form. I know there is some variation outside Leeds, so again, check a referral form in your locality, because it may be necessary for the GP to complete a referral form, a 2-week wait referral form, if appropriate to do so, if the FIT test is positive. So that's FIT positive patients. What about FIT negative? Because they're actually going to be the majority of patients that we request a test for. And you'll see on the pathway flowchart that there are 3 possible routes for these patients. Looking at the box on the left-hand side, so that's as patients who we can be quite reassured by, really, because they've got symptoms that have resolved, and otherwise reassuring tests. So the FIT test is negative, the blood tests are quite reassuring, there's nothing on examination which has worried us. So for this group of patients, it's appropriate just to give reassurance and also safety netting advice, ensuring that patients are aware of red flags and also when to represent to primary care if they have recurrent or new symptoms. Looking at the next box along, you'll see that the group number 2 of FIT negative patients are those that maybe have some lingering symptoms, for example, intermittent rectal bleeding, they might have resolving, change in bowel habit, but otherwise the tests are reassuring. So what do we do with these patients? Well, it might be appropriate, for example, to refer routinely to gastroenterology or to colorectal surgery, or a GP might choose to do a repeat FIT test, plus or minus a fecal calprotectin if it's appropriate to do so. And then the final, more concerning group, the third box on the flowchart, this is for patients who have persistent symptoms, but otherwise the tests so far have been reassuring. So you might choose to do, for example, some additional blood tests at that point if they've not already been done, for example, CA125 for females, PSA for males, and other tests could include, for example, TFT, celiac screen, HbA1c. Now, what we do next might be dictated to us by the results of the test. So, for example, if the PSA is raised, that would necessitate a 2-week wait referral to urology. If the CA125 likewise is raised, that would necessitate a referral on the 2-week wait pathway to gynecology. But of course, there may be a group of patients where it's not immediately obvious to us from the test results what direction we need to go in. So with those patients, if they have persistent concerning symptoms, then it might be appropriate for them to refer on the non-specific symptoms pathway, which of course is treated as a 2-week wait pathway, so they will be investigated with equal urgency.
That's really helpful, thank you. So as we've already sort of briefly mentioned, the Cancer Alliance is funding fit navigation teams across the localities, and the role of the fit navigators is primarily, as Robert's explained, to help educate patients and help them comply with the test. We do see a high volume of fit tests which are spoiled or rejected due to incorrect labelling or overfilling of the samples. Hence why the navigators are there to really contact the patients and coax them through and explain the process to enable them to get a fit test that's able to be interpreted in a timely manner. We do obviously are aware that the fit navigators will have slightly different roles in different areas to support differing needs of local populations. But the basis of the fit navigation team is really to safety net the patient, and if they can't get compliance, then they will send messages back to the referring clinician that they haven't been able to help the patient complete the fit test, and then it is, as we've said, the responsibility of the referring clinician to decide what the most appropriate next steps are. So shall we talk a little bit about risk? Rob, I know you've had some feedback from colleagues about risk.
Yeah, that's right. So I've been having discussions with colleagues about the new pathway, and one of the themes that's come up a few times is for patients, for example, who are fit negative, but who have symptoms that would have previously been referred on the old pathway as a 2-week wait. There's been a concern raised about what to do with that cohort of patients, really.
Absolutely. And Rick, could you give us your viewpoints on what this level of risk represents?
Yeah, so I think the first thing to say is that no test is perfect. So colonoscopy is our sort of gold standard test for picking up colorectal cancer, and we know that it misses colorectal cancer. And just to give you an example of that, if you recolonoscope people 3 years after they've had an index colonoscopy, somewhere between 5 and 7% of them will have a colorectal cancer. So no test is perfect, that's the first thing to say. However, FIT is pretty good. It is over 99% sensitive for picking up colorectal cancer, and in those patients where it is negative and colorectal cancer is found, those tend to be patients who either have obstructive symptoms or who have very early right-sided tumours. Now, hopefully, the message from today's seminar is that it isn't just about FIT, it's about a clinical assessment, including an examination, which hopefully would pick up someone who's obstructed, and it's also about identifying iron deficiency anemia via the blood tests. And so hopefully FIT should be regarded as part of a suite of tests to prompt urgent referral.
Okay, that's really helpful, thank you. And Rob, managing risk is a core element of general practice, isn't it?
It is, yeah. It's something that we're comfortable doing. We do it on a daily basis, and I think that we're comfortable doing it, especially when the criteria for escalation are quite clear to us. And I think something that this pathway does achieve is making it quite clear when when it's appropriate to escalate, especially because the evidence around FIT test so far is really quite reassuring. So for those patients with a FIT test result of less than 10 who have reassuring examination, other test results are also reassuring. I think most GPs would be confident and comfortable in safety netting those patients in primary care. And of course, if there are patients who a GP has persistent concern over, as we've already covered in the pathway, there's always a route that a GP can refer in for urgent assessment if needed.
Excellent, thank you. So when there is a change in clinical practice, we know it takes time for clinicians to really digest and understand the evidence base and the rationale for change. When assessing any patient for a risk of cancer, we're already familiar in primary care of the other investigations that we use to triage patients, as we've alluded to already on the pathway. And indeed, none of these tests are perfect either. So CA125, in terms of blood tests, that has a miss rate of around 23%. Chest x-rays can miss lung cancers. Around 20% of lung cancers will be missed by a chest x-ray. So as we've already all agreed, it's important to use clinical judgment alongside investigations and provide robust safety netting if we're going to use a watch and wait approach for patients. So I think it'd be helpful just to discuss a few clinical scenarios. So if as a GP I was to see a 33-year-old with symptoms that are suggestive of irritable bowel, Rick, what would you suggest now I should be thinking of in terms of investigations for a patient such as that?
So historically, if you look at the NICE criteria for referral, that patient would not end up getting a 2-week wait colonoscopy, predominantly because of their age. They would almost inevitably be assessed in primary care, and then they would be referred routinely to gastroenterology and would eventually have a colonoscopy some months later. I've already alluded to the fact that we're seeing increased prevalence of colorectal cancer in young patients, and so historically that colorectal cancer in a 33-year-old we see presenting late with the old referral guidelines. With our new guidelines, however, that 33-year-old will, in addition to clinical assessment and blood tests, will have a FIT test. And if the FIT test is positive, they become a 2-week wait referral. They have a timely colonoscopy, and hopefully, if they do have colorectal cancer, that's picked up earlier and can be dealt with effectively.
Fantastic, thank you. And Rob, if I was to see a female in my GP practice who had persistent diarrhoea and some weight loss, and the clinical examination was normal, blood tests were reassuring, the FIT test was less than 10, what steps would you think I should take from thereafter?
Yeah, so I think with a patient like this, there would be a continuing concern about potential cancer because they've got a weight loss, they've got persistent change in bowel habits. From what you're saying, it sounds like they've had some reassuring investigations. They may have had CA125 as a female as well. And if all of that was reassuring, but they had these persistent symptoms which were concerning, then it may be that the next best step for them would be referral on the non-specific symptoms pathway, for example, which, as we know, is treated with the same urgency as a 2-week wait. And the reason for that is partly because, of course, we know that about 25% of patients who present with pancreatic cancer have abdominal symptoms, present with abdominal symptoms. So it's important to get them investigated urgently so as not to miss this group of patients.
Okay, thank you, that's really helpful. And what if I have a patient who just won't or can't complete the FIT test?
Well, I'm glad you raised that, Helena, because I think that's a really important safety net that we've built into the pathway for West Yorkshire clinicians and for patients. And so for patients who we're concerned about because they've got persistent symptoms and they're not, for whatever reason, not able or they won't complete a FIT test, there's always the ability to refer those patients immediately on the 2-week wait pathway, giving a clear rationale for that referral at the same time.
Thank you. So we know here in West Yorkshire and Harrogate we've been somewhat slower to implement the FIT pathway as a primary care triage tool. But we now have plenty of evidence from other areas that this is working very well and making a difference in terms of patients accessing services appropriately. Rick, what are your views?
Yeah, I'd agree. We've been slower than many cancer alliances in rolling this out, but I think we've had justifiable safety netting concerns, which we've addressed with this new pathway. In particular, the recruitment of navigators for each locality is going to be pivotal in delivering that. And I think we're now in a position where the pathway is set to be rolled out and will work well.
Great, thank you. So everyone's asking now, when is this pathway going to be implemented across West Yorkshire and Harrogate? Rob?
When Leeds, it's already live.
Fantastic. And we know all the other localities are working incredibly hard at the moment. They have their FIT delivery groups and they're aiming to deliver the new pathway sometime in the autumn. So if we have to pick one key thing that we feel is the major improvement in the pathway, Rick, what would yours be?
I think for me, it's getting rid of age as a barrier to 2-week wait referral. We've talked about colorectal cancer being more prevalent in younger patients, and I think that for me is the single biggest change that's going to make a difference here in my practice in secondary care.
Great, thank you. And Rob, what would yours be?
I think for me there are some really good safety netting measures that have been baked into the pathway for both clinicians and for patients in the West Yorkshire region, particularly around safety netting for negative patients and also those patients that we know won't be able to complete a FIT test. There's always a way for GPs to get patients assessed urgently if they need to do that. How about you, Helen?
I think it's really making sure that no patient is excluded from referral based on the ability to do a FIT test alone. So we will be posting this education piece on the West Yorkshire and Harrogate Cancer Alliance website, along with other education material both for patients and clinicians. And I just wanted to finish by saying thank you so much to everyone for their continued commitment to roll out this pathway, which we know has been complicated and complex, but really will, deliver the right outcome for our patients in West Yorkshire and Harrogate.
Yeah.
Thank you.